What's up, guys? Dr. Chris here, and today I want to talk about 6 pain mechanisms. Basically, this is answering the question of why do you hurt? Now, almost everything in this video comes from the work of Annie O'Connor. She's a physical therapist, and she wrote a book, and she's part of an organization called The World of Hurt, and I'll put a link in the description. I highly recommend you check her out. She does awesome things. Every patient needs 4 questions answered. Number 1, why do I hurt? Number 2, what can I do for this problem? Number 3, what are you gonna do for this problem? And number 4, how long is this gonna take? So these 6 major pain mechanisms aim to answer the question of why. That's what our focus is gonna be on today. And the major reason why we do this is because we want to make sure that we match up treatment with the actual mechanism. So let me give you an example. If I have a bone fracture, then it's pretty obvious. I need the bone set, or the bone needs to be reduced by an orthopedic surgeon, maybe immobilized, maybe pins and screws. The treatment is matching the mechanism. If I have diabetes, then I'll need medication or a lifestyle change in order to reverse or manage the diabetic condition. Again, that treatment is matching the mechanism. Same thing if I have a cancer. I'll need the treatment approach to match the classification of cancer that I'm dealing with. When it comes to pain, I see a large mismatch. So let me give you an example. I'll have a patient that will tell me that he has used acupuncture and massage in the past, and it's really helped him out. He said, hey, I love it. I know this guy, he does a great job, and I always feel way better after both, either one, massage or acupuncture. The next time he does acupuncture and massage, he doesn't get the same results. Why is that? Well, I'll explain to him that usually the reason why you're getting results from something like acupuncture massage is because you have a stress-related pain. So acupuncture massage is excellent. Increasing blood flow, improving relaxation, breathing changes, all that is good. But the second time around, he has a tendinopathy. And of course, acupuncture massage may help a little bit, but it's not going to resolve the case because the treatment is not matching the mechanism. In my practice, I'm really very intentional, or at least I try to be, with every single patient on matching the treatment with their mechanism. The stress-related pain can do really well with acupuncture and massage, but a tendinopathy is not going to likely resolve from that. So I like to make sure that all of my communication, my manual therapy or hands-on, and exercise is matching the classification or the mechanism of pain. That's how we get to the root cause of the problem. All right, let's get into the 6 major pain mechanisms. Pain mechanism number 1 is inflammation. Now, to describe inflammation, it's pretty self-explanatory. The body went through some trauma or stress, and it sends out inflammatory chemicals in order to create a healing environment and repair the tissue that needs repairing. So some easy examples of inflammation is a sprained ligament or a strained muscle, in which the fibers of the ligament or the muscle have just partially torn, and then the body sends out inflammation. Another example is bursitis, where the bursa sac near the joint is having an inflammatory process. You could also have joint or bony inflammation in the form of rheumatoid or osteoarthritis. The key to managing an inflammation problem is it's pretty obvious, right? It's you protect it, then you create a healing environment, maybe you do some gentle movement, and you give it time. You don't want to stress it too early. Now, of course, if you have a problem that really lingers on and it's just not doing well and it's this perpetual inflammation cycle, then you may need to manage it with medications or even an injection. But the key thing here is that inflammatory process or fluid and those chemicals, they need to clear out once they've done their job. That's pain mechanism number 1. Pain mechanism number 2 is ischemia. Now, what ischemia means is that there's a lack of sufficient blood flow to the tissue. That means there's going to be a reduction in oxygen and nutrients to those parts of your body, those tissues or those organs. So an easy example of an ischemia is a tendinopathy. So if you think about your patellar tendon on your knee or your Achilles tendon, you can deal with a lack of blood flow and again, have less oxygen and nutrients and less elasticity, and you could have pain because of that. You can also have what's called a frozen shoulder or adhesive capsulitis, which that one kind of fits into category 1 and 2, inflammation and ischemia, in which the capsule of the shoulder, which is just the tissue that surrounds that ball and socket, undergoes some trauma and shrinks down. When that shoulder capsule shrinks down, there's not enough room for movement and you get this stiffness of that tissue. Usually the treatment approach for that one is going to be an injection, subacromial or intra-articular, so that you can soften up the capsule and regain the elasticity. Overall, the treatment for an ischemia is actually to remodel the tissue. It's kind of that mantra where you need to create pain to get over your pain. So when I see this in the clinic where people will have a true patellar tendinopathy, like where their knee joint is hurting in the front or their Achilles tendon, again, had that strain and then there's lack of blood flow, we need to exercise through that, but it needs to be done intentionally. Again, where we create some pain and that pain goes away. We produce a little bit of discomfort and then it doesn't linger, it goes away. This is the remodeling process so that we can restore blood flow and health to the tissue. That's pain mechanism number 2, ischemia. Pain mechanism number 3 is called peripheral neurogenic pain. So if we break down that term, peripheral means just away from the center. So there's peripheralization that goes down my arm, and there's centralization where it's near towards my spine. Neurogenic just refers to pain that is coming from the nerve. Really what peripheral neurogenic pain is there's an irritation to the spinal nerve root or a peripheral nerve that is outside of the central nervous system, the central nervous system being brain and spinal cord. Some easy examples of peripheral neurogenic pain are carpal tunnel syndrome or sciatica. A lot of times I see cervical radiculopathy or lumbar radiculopathy, in which there is a tight nerve or a trapped nerve in the neck and there's pain going down the arm. So the treatment approach for a peripheral neurogenic pain really involves a good examination. We need to figure out if the nerve is tight or it's trapped. Once we figure that out, we want to put you on a progressive exercise program, or I call it a PEP, that reduces, abolishes, or centralizes that pain. Put in easier terms, we just need to simply decrease your pain, get rid of it, which is abolish, or centralize it so that pain that is going down your arm goes back up towards the source. Ultimately, we want to restore joint mobility once you have this peripheral neurogenic pain. This one can be a little bit confusing at times because patients will tell me, hey, I've got this like hip pain and it goes down to my calf and my back doesn't hurt, it's really just my leg. And meanwhile, back movements or lumbar movements are causing that pain to reduce, abolish, or centralize, which is giving evidence that, hey, it actually was coming from your lumbar spine and we need to restore that joint mobility and that pain should go away. That's pain mechanism number 3, peripheral neurogenic pain. Okay, we're gonna take a quick intermission just to give you like an overall umbrella view of all 6 pain mechanisms right now. The first 3 pain mechanisms that I just went over, inflammation, ischemia, and peripheral neurogenic. The thing that those 3 have in common is that the pain signal is going from the tissue, the peripheral tissue, to the brain. Now, the next 3 pain mechanisms I'm going to talk about are the opposite. Those are signals that go from the brain to the tissue. Now, before you shut off the video and say, no way, this pain for me is coming from my body and that's all there is, we need to take a quick pause. The thing that I see a lot is that people's pain doesn't just fall into one bucket. yes, you may have a peripheral neurogenic pain mechanism, and that's 80% of the problem. But you can have 10 or 20% of the problem that is coming from brain signals that are maybe sensitizing your body or giving you some false information. That's why these next three pain mechanisms are so important to go over. In the central nervous system, which again is brain and spinal cord, we have to remember that our brain is an organ of protection. The way that it protects us when it comes to pain is this. There's three ways. It overprotects, it diverts, or poor coping, or number three, it neglects and forgets. So let's go over those last three pain mechanisms. Pain mechanism number 4 is central sensitivity, or it's that overprotect program that your brain is running. So a lot of people will think there's no way, this stuff is coming from my body, this can't be coming from the brain, but it really can. Remember, the brain runs programs. If you've gotten injured and then you're healing and your brain deems it safe, then you're gonna have good tissue movement, you're gonna have good sleep, good function, there's gonna be no sensitivity. But if you get injured and your brain is still running the program that says, hey, we need to protect, then you're going to have decreased function, increased pain, increased tissue sensitivity, maybe some increased inflammation, some decreased sleep, and just this cascade of problems because again, the brain is running the program of let's protect. The way this shows itself in the clinic is usually two ways. Number one, I'll see some fear avoidance where it's like, hey, I don't really want to move that way. I don't think I'm ready. Number two, I'll see a latency response where someone will do pretty well in the clinic, but there's no carryover. They'll feel pretty good, they'll move well, and they go home and 2-3 hours later, they don't feel good at all. Or they'll use the language like, hey, I can do this right now, but I'll let you know how this feels 8 hours from now. That's a latency effect. That's the brain having time to process what happened and then making a decision on whether or not it's going to give you a lot of pain signal or not. So the way that we treat this central sensitivity is through the traffic light system. Red light means worse, yellow light proceed with caution, and green light means go. Or an easy way to think about that is better, same, or worse. The rule in my clinic is that you have to leave either better or the same. We cannot make you worse. That is not the purpose of rehab. So here's an easy example of how we would treat someone with a central sensitivity. We would first set a baseline. So for example, I would have them rotate their neck. As long as it's meaningful to them, the baseline has to be important to the patient. So they'll start with their baseline. Okay, if they think that feels okay at a baseline, then we'll start exercising. We'll do bicep curls, we'll do shoulder raises, we'll do treadmill, maybe some functional activity, and then we'll recheck the baseline. They have to tell me if it's better, same, or worse. If it's better or the same, that's the green light or yellow light, that means continue. You are reprogramming your brain that, hey, we don't have to overprotect, we are safe. We just have to move methodically. I found over the years that this way of treatment, it's like the secret sauce for patients. We're teaching them how to be their own diagnosticians by their own testing. The same thing can happen in the low back or the shoulder or whatever it is. If someone is fear avoidant of the shoulder, I'll set a baseline. Hey, reach overhead. That feels okay right now? Great. Let's exercise. We'll do some movement, some elbow work, some more reaching overhead, and then at the end, we'll recheck the baseline. Go ahead and show me it again. If that feels safe, great. That is a green light or yellow light, meaning we are safe to move on. That is pain mechanism number 4, central sensitivity. Pain mechanism number 5 is referred to the affect group. Now, this group is dealing with a more emotional and psychological pain, sometimes referred to as psychosomatic. Now again, before you turn off the video, this one is really important because in my practice, I have yet to meet someone that has actually come forward and said, you know what, I think my pain really is like signals that are coming from lack of coping. It's my brain is diverting away from the actual problem. The shoulder's actually fine. I think that some of this is in my head. Nobody ever says that. No way. That's not how it works. But the brain is super powerful and it can cause some really crazy things to happen in the tissues, meaning mild oxygen deprivation or a lack of some blood flow to the tissues if you're not coping well. This stuff gets a little bit heady, so I'm going to read directly from Annie O'Connor's book and her work to describe the affect category or pain mechanism so that you can get the best information. The theory here is that the unconscious mind uses the ANS, which is the autonomic nervous system, which regulates the internal organs to decrease blood flow to muscles, nerves, tendons, and organs, resulting in oxygen deprivation that is experienced as pain in affected tissues. Diversion. The physical pain is the body's defense mechanism to distract the person from the unconscious mental emotions. You're not crazy, but you're not coping. Some people refer to this as psychosomatic or mind-body disorders, somatization, that's the word, and psychology. The brain recognizes that you may not be coping so well, not coping with anger, anxiety, the trauma related to this injury, not coping with things that we have repressed, inferiority, shame, resentment, guilt. The brain says, she's not coping with this and needs help. I am going to create symptoms in some body parts she thinks is important, and she'll go get help. The issue is not the tissue. The issue is the brain recognizing that they are not coping. The brain can deoxygenate a tissue. Brain can decide that your Achilles tendon does not get blood flow, maybe during a long run. Or the brain decides that it devascularizes, less blood flow, to the supraspinatus tendon, that's in your shoulder, during a tennis match. When it comes to treatment of these problems, the psychology needs to be addressed. Now, again, I've mentioned this before, that two things can be true. You don't have to have all of your pain coming from the affect or the emotional centers, but it could be a percentage. Maybe you do have some ischemic problem, but maybe that's 20%. And maybe the 80% is that there is some stress-related problem that is coming from the emotions that is making this worse. And that really needs to be addressed. This one is really important. A lot of people will overlook it and say, no, that's not me. And they'll spend a lot of time and money and energy on getting treatment, becoming dependent on practitioners and people to help them, when really they need to address the psychology and heal that inner child or that inner emotion that is causing some worsening of symptoms. That's pain mechanism number 5. It's called the affect group. Pain mechanism number 6 is referred to as motor autonomic, or simply put, the brain has neglected or forgot some of its representation and some of its movement patterns. In neuroscience, we have what's called a sensory and a motor homunculus, which is basically like a small limb that's imprinted right here in our brain. And it's a representation, like a map, of how we're supposed to move. When you have this type of condition, the brain has lost some of that representation. We refer to it as cortical smudging. So here's a concise definition of what cortical smudging is. Cortical smudging happens when the brain's map of the body gets blurry, leading to confusion about where a limb is or even feeling disconnected from it. This can result in a sense of disownment or difficulty coordinating movements. It's common in conditions like chronic pain or after an injury. An extreme example of cortical smudging would be an amputated limb. So if I had my leg amputated, then the map in my brain would compensate. It would no longer need that leg on my motor map, and it would take those neurons and that blood flow, and it would divert it over to other parts of my body so that I can function at a high level without the limb. That is that cortical smudging that is happening in order for you to continue functioning. Now, where I see it most often is with people that have had low back pain or an ankle sprain for greater than 6 months. After a while of compensating, the brain starts to neglect and forget certain patterns. They become dysfunctional. So, for example, I'll ask someone that has had this low back pain to move their pelvis in space, or someone with an ankle sprain to squat down, and they just feel like it just feels off. Like they tell me things like, I can't really feel my hip or my glute, or my right foot, it doesn't feel like it's like solid. I don't feel sure-footed. Those are common things that I hear. So how do we treat this? Number one, it starts with a good evaluation for finding those dysfunctional patterns. Then number two, I always start with a mirror to give people visual feedback to see how they're moving in space. After that, I like to load the tissue once they're in that neutral space to get them to ground. Basically to find areas of compression so that their body can feel and sense that part of their body again. The body has an amazing way of remapping itself and pushing you away from injuries and basically compensating. Put simply, those dysfunctional patterns need to be remodeled in the brain. They need to be retrained again because at some point down the road, we've lost that motor mapping. That's pain mechanism number 6, motor autonomic. So there you have it, your 6 pain mechanisms. But I'm just going to mention a couple more things here. There are still drivers of disability and pain. There's 3 main drivers. Number 1, comorbidities. Number 2, cognitive and emotional states. And then number 3, context. So for example, comorbidities. If you have someone that has metabolic disorder, where they have hypertension, diabetes, they're very overweight, their time frame for healing is going to be different than someone who is more healthy, that has different blood flow. In the cognitive emotional group, if you have someone that is more stress oriented or just has different factors going on at work and just a lot of life going on, again, they may have a different driver towards pain and disability. And then of course, context really matters. There's a great example of what happens when you get a paper cut if you are a violinist versus a truck driver. If you're a truck driver, you're not really worried about the paper cut. But if you are a violinist, that paper cut might be worth more, might have a lot more weight to it than it would for the truck driver. Just keep that in mind, that there are drivers of disability and pain. In conclusion, those are your 6 pain mechanisms. You have inflammation, ischemia, peripheral neurogenic, central sensitivity, affect, and then motor autonomic, plus a few drivers of pain and disability, which are comorbidities, cognitive emotional, and of course, contextual. Just to wrap up, reminder for you is that 2 things can be true. You can have peripheral neurogenic pain plus some central sensitivity. The most important thing is that you find your dominating pain mechanism and then match up the right treatment with the right mechanism. My hope for you is that you would find full resolution to your pain. If you find this video helpful, please like, comment, subscribe.